These lectures are not designed for use as medical references to diagnose, treat, or prevent medical or mental health illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or mental illness, you should consult your personal physician or other mental health professional.
The opioid epidemic is devastating our country. Overdoses have now surpassed car crashes and gun violence to become the leading cause of death for Americans under the age of 55. The epidemic has killed more people than HIV at the peak of that disease, and its death toll exceeds those of the wars in Vietnam and Iraq combined. Funerals for young people have become common. Every 11 minutes we lose another life. So why do so many people start using these drugs? Why don't they stop? Welcome to today's lecture on addictions, now more formally known as substance use disorders. We'll focus mostly on opioids because there's been such an incredible rise in prevalence rates for opioid use disorders and overdose deaths, mostly triggered by the overprescribing of pain medications. In our first CBT course, we included alcohol and other substances, and you'll see the tools we pull from the toolbox are quite similar. So how did we get here? Well, in the mid-90s, there was a reconceptualization of pain as the fifth vital sign. You go to the doctor, they measure your blood pressure, they take your height, they take your weight, and now they ask you about pain, usually on a 1 to 10 scale. It increases awareness, but also sensitivity, and maybe nudged doctors a little more to prescribe pain medications. There was also high pressure from drug companies in marketing the different drugs, such as OxyContin or oxycodone. There were a number of less scrupulous doctors or medical facilities, now called pain pill factories, that were all about making money, but also getting people hooked on these expensive medications. Some have argued that maybe our opioid crisis is the sign of broader societal distress. Is it about income inequality? Is it about depression? Is it about the lack of connection with others? Let's explore that and see. Around 2 million Americans are addicted to opioids, yet many more have overcome their addictions. A large national study found that nearly all of those who once met criteria for opioid use disorders achieved remission during their lifetimes, and half of those recovered within 5 years. Although heroin and street fentanyl are more dangerous, most of those who avoid fatal overdoses recover from addiction. Let me repeat that. Most of those who avoid fatal overdoses recover from their addiction. Let's not write these people off. If you're wondering how, it wasn't through old school abstinence. It was through something called medication-assisted treatment, where medications like buprenorphine are used to stop withdrawal and promote recovery. Studies have shown that these types of medications reduce mortality by half or more when used long-term, and they cut relapse rates, more than an abstinence-only approach. Other people, they take their own routes entirely. They might find new passions in relationships, parenting, culture, exercise, work, art, spirituality, activism, and community service. Some recover by learning better ways to manage the trauma and mental illness that underlie many addictions. I've learned not to ask why the addiction, but instead to ask why the pain? Why the isolation? Why the lack of connection? Johann Hari, the author of Lost Connections, argues that the opposite of addiction is not sobriety. The opposite of addiction is connection. Bruce Alexander, an addictions researcher, supports the notion with his rat park experiments. He gave rats 2 types of water bottles, one with just water and one with water that had been spiked with either heroin or cocaine. Rats only preferred drugs when the cage was empty. If they had companions, if they had things to do, the rats actually chose the water only. If you look at the example of Vietnam veterans, many of them used heroin. 95% did not get hooked. They came back home to their lives and their families, and they didn't need it anymore. What if addiction is about your cage? What if addiction is about a lack of connection? Regardless of the path and whether or not assistive medications are used, we're going to need our CBT toolbox, but there are quite a few tools that we need to add. Here's a quick rundown of some of the skills that we will discuss. First is an increase in self-awareness and self-monitoring. And here these are the usual things such as our mood, depression, anxiety, but we're going to add in things such as triggers for substance use, and we're also going to add in the quantity of a substance that's used, or maybe adherence to a medication that's been prescribed to help. We're going to add in problem-solving skills. We're going to add in something called refusal skills. Now remember that our social networks are often the drivers for the choices we make about whether or not we use drugs at a particular occasion. Learning how to refuse drugs from your social network is an important skill to cultivate and develop. We'll teach people skills on how to cope with cravings. Remember, oftentimes folks have irrational beliefs that the craving will continue to escalate and then become absolutely unbearable. What usually happens is, yes, there is a physiologic craving, it reaches a plateau, it evens out, and then it eventually goes back down. Other skills will include learning how to manage stress, learning how to regulate emotions without the use of chemicals, learning how to make healthy lifestyle changes, diet, exercise, getting better sleep, learning stimulus control. So if there are certain things that trigger you, removing them from your life, from your world, if possible. Building those new healthy social relationships and connections, either with family, friends, community organizations, churches, or others. Cognitive restructuring, and here we're talking about our thought records, but again, using them specifically around triggers around drug use. We will include things like behavioral activation and behavioral scheduling. Remember, people that have developed chemical addictions often have anhedonia or have difficulty enjoying things that they used to enjoy. It's because their body is so used to this surge of dopamine, the pleasure chemical, that it takes a lot for them to be able to enjoy themselves. So we're going to have to work particularly hard in this area. Now, CBT helps patients overcome substance use disorders by helping to dismiss false beliefs and insecurities that lead to substance use disorders, by providing self-help tools to improve their moods, by teaching effective communication skills. We teach patients to recognize, avoid, and cope, to recognize which circumstances lead to using drugs or drinking, to avoid triggers whenever possible, to cope using CBT techniques to regulate emotions and challenge thoughts. Recognize, avoid, and cope. Let's dig a bit more deeply into the use and misuse of opioids for pain and how that might lead to an opioid use disorder by looking at a new clinical case. We'll use this case to illustrate many of these new tools. Now, Scott is a 50-year-old married man referred for CBT by his pain management doctor. He was diagnosed with degenerative disc disease in his back, which caused him to have a pinched nerve that radiates pain all the way down his leg and makes it difficult to walk whenever he's having a flare-up. He's been on several high-dose opioids for years now, and he hasn't really gotten any better. Now, his doctors want to taper down his pain medications and add in other treatment modalities. Let's pick up when I first met him, and he tells me he's getting into trouble. So there's pain management. You said that you're kind of getting in trouble with your pain management. Can you say more about what you meant by that?
Well, I mean, you know, I started on just ibuprofen for the pinched nerve. But do they tell you that that's what I've...
Yeah.
So the thing is that made me sick to my stomach, and you know, I was told by a medical doctor, by two medical doctors, that it was appropriate to start some opioid-based medications because the strength of the pain required it. And now I'm in a situation where I can't, where I'm starting to up the doses and where I'm starting to abuse it. But that's not my intent. The intent was just to be able to be functional.
Right. Well, and I see from your chart it's been several years of chronic opioid use, and it looks like the number of medications and also the dosage has been kind of climbing. Is that accurate?
Yeah, that's the way it's worked out. Yeah.
Okay. And why do you think it's been climbing? Is it just for pain management or something else?
I'm not taking it to get high.
Okay.
Just that. Have you ever had a pinched nerve? It's not.
It's painful.
Yeah.
Yeah. Okay. Now, as I said, pain management first and foremost, but we want to do that in a safe way. And I think where you are now is where a lot of people, unfortunately, have found themselves as they've gotten on this pathway where they have to use more and more and more and more opioids. And eventually, the opioids, the drugs themselves, become a problem on top of the pain. And their pain still isn't controlled the way they would like it to be. So I'm glad that you were referred here, and I know the Pain Management Center wants to kind of put the brakes on the opioids and talk with you about maybe diversifying into other kinds of medications, tapering things down, but at the same time you working with me and others to manage your pain as best we can. Does that
Yeah,
sound okay?
I don't like being on opioids either. I just don't know about all these other techniques, so if you can tell me about them, that's fine.
Sure.
You know, it's not pleasant to be on opioids either. I don't like being constipated. I don't like being sleepy. I don't like not feeling like myself, like I haven't felt for 2 years. So this wasn't my idea, you know?
Right. And I applaud your coming here, and I know it's not easy, especially with something like pain. It has a way of grabbing your attention and just sort of taking over your mood and affecting your relationships and making it hard to function.
That's all you can think about.
Absolutely. And so it makes sense that you would reach for something or go to your doctor who gives you something to try to manage the pain. You've probably picked up that his emotion and the energy between us is a little bit different, at least initially. He's frustrated, he's angry, he's defensive, and he's almost preparing for combat. He feels betrayed by his doctors, but he also doesn't want to give up his opioids, which he believes are still his best option for his pain management. Let's continue. If it would be okay, I wanted to ask you a few questions about things that sometimes happen to people when they're in that path of escalating use. Mm-hmm. Sometimes their doctors will stop prescribing or they won't increase a dosage even though you're still in pain, and people go to other sources. They go to other doctors, they maybe go to friends or family members. Has that ever happened for you?
Yeah. When my prescription wasn't enough, my mom had some leftover pills after she died, and so I used some of those for a while. And of course, those ran out, and then I had to seek out someone else. I mean, I probably understand why they didn't want me to have any more, but you know, I wasn't going to argue with that last doctor, but I still did need something else, so I went to another one.
Right. So you did what you felt you needed to do, and that's
every step of the way, just kind of what I need to do to get by.
Yeah, and I think the effects of that can be at least twofold. One is, you of course are trying to manage the pain, and you feel the frustration at not being able to do that, and maybe not getting the medical help or support that you need. But the other part I think is psychological, and when you have to take pills from family members or from your mom's leftover pills, it does something to the way you feel about yourself.
Yeah,
sometimes.
well, I haven't really always been able to be honest with my wife about it either, because since she doesn't have the condition I have, I think she doesn't quite. You can't see the pain from the outside, right? So I look fine, right? So why should I need more? So I have to take more than a doctor thinks I should. I have to take more than she thinks I should. So. You're doing things behind people's backs, and then that's bad for your relationships.
So you're left in a position where you have to keep secrets, and when you start keeping secrets, especially from your wife, your significant other, and friends and family, then you're right, it plants the seeds for all sorts of other problems and potential conflicts.
Yeah.
So again, I'm glad you're here. I want to make sure I have the full extent of the things that you've been through trying to get your pain managed. Have you ever purchased pain pills from anyone on the street or from other sources?
No, well, we're not there yet. I wouldn't know where to go to do that anyway.
Okay. And have you ever used things like heroin or other opioids?
No. Sometimes I drink more than probably I should, just to give a little extra numbness.
Okay.
Sometimes I just want to be kind of numb and mellow because, you know what it's like after you've had a bottle of wine, you're just feeling no pain in general.
Right.
Probably isn't good to mix those things. But.
Right. So and you're again sort of when you're the feelings of frustration and desperation you have in managing pain, you're reaching out for other substances too. And you're right, mixing alcohol and opioids isn't a safe idea because they have a synergistic effect, really. One sort of amplifies the others, and then you have other different set of problems that come up. So again, I'm glad you haven't had to go that far of going to other sources to buy opioids. Haven't yet used heroin or other things, and we want to keep you from going there. So I'm glad you're here to do something about it. Scott finds himself in a situation that thousands are in. In good faith, he saw his doctor about pain. He was given opioids, and he felt a little bit better, at least in the short term. But soon he needed more, and then he needed more, and then he needed more. The focus was so much on the sensation of pain that he forgot about improving his level of functioning. He was trapped in a cycle of needing more and taking more. As part of this process, he became physically dependent on opioids, and he would get sick, literally physically sick, not just feeling the pain, if he didn't keep taking his opioid medications. It seemed like there was no exit except to keep going up in his dose. Then someone shut off the pipeline of drugs and tells him he has to taper down and maybe even stop. No wonder he feels angry and betrayed. But this is where we are, and we have to do something about it. Now, let's talk about this process that he's trapped in. He's in a spiral of something called hedonic dysregulation. Recall that when someone is using a drug like an opioid, it activates our endogenous opioid system, which is why it helps us with pain. But it also releases dopamine, which helps us with the experience of pleasure. If he's getting more and more and more dopamine because of his opioids, it means he's going to require more and more and more dopamine to enjoy his everyday activities. He's enjoying things less and less because of the medications that he's taking. He's unable to enjoy time with his family. He's unable to enjoy time with friends. We know that because of that, he's probably going to be at increased risk for depression. He's going to be less able to derive joy from his life. One of the first things we need to assess is whether or not Scott has an opioid use disorder. Just like with all the other potential drugs of abuse, we use the DSM diagnostic criteria. So let's take a look at the DSM diagnostic criteria to see if he meets diagnosis of opioid use disorder or not. Either way, this is a clear problem that needs to be addressed. Here are the DSM criteria for an opioid use disorder. Now remember that you need at least 2 to 3 of these in order to have a mild disorder, 4 to 5 to have a moderate level of severity, and 6 or more to be considered severe. Criteria 1. Opioids are often taken in larger amounts or over a longer period than was intended. 2. There is a persistent desire or unsuccessful efforts to cut down or control opioid use. 3. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover from its effects. 4. Craving or a strong desire or urge to use opioids. 5. Recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. Next, continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. Next, important social, occupational, or recreational activities are given up or reduced because of his opioid use. Next, recurrent opioid use in situations in which it is physically hazardous. The next criteria is continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that's likely to have been caused or exacerbated by the substance. In the last 2, he exhibits tolerance, needing more and more and more to have the same effect, or exhibits withdrawal. If he stops taking it, he's going to have withdrawal symptoms. Now, these last 2 criteria are typically not used if a person has been prescribed pain meds and they are following their prescription. Note that in this particular case, however, he's taking more and more opioids beyond what has been prescribed. So which of these criteria did he meet? Well, he's taken more than intended and he's run out early. He wanted to cut back, but he failed. And this isn't just about willpower. He has cravings and he has urges. He has tolerance. He has withdrawals if he stops. So he's positive for 5 criteria. That places him in the moderate range for an opioid use disorder. So what can we do to help him? First and foremost, he needs other ways to manage pain, but he'll still want opioids. We can start with self-monitoring for pain, and we probably want to measure or monitor his opioid use. We want to include measures of functionality, his physical health, his mental health, his social contacts with other individuals. We want to keep track of his mood and also his stress levels. As with all cases, we would want to do some goal setting, but here we need to carefully coordinate with his medical providers, and it would probably be good to include his wife in this process so that she can provide appropriate support. So let's go back and look at some CBT skills we might use. Remember that these fall into the cognitive or behavioral buckets, and they target either emotion regulation or interpersonal relationships or some other form of functioning. Addiction and its fallout certainly include both of those. In thinking about tool selection, it's important to first think about some of the cognitive and behavioral phenomenon that contribute to addiction. Here are a few key examples to consider. From the behavioral and environmental factors, we want to look for high-risk situations or areas. So they are the places that people typically use a substance or the people that they typically use a substance with. What are the triggers? What sorts of social network behaviors might be promoting the use of the substance? Is there a biological predisposition? Does this particular type of addiction run in their family or not? Do they have cravings for the substance, and what are their strategies to go about coping with those cravings other than taking more of the substance? What are the rituals or habits that they have developed around drug use? Cognitive factors to consider include dysfunctional beliefs about drugs, oneself, and about one's relationship with drugs. It often starts as a love story, but it doesn't end that way. It might also include automatic thoughts that increase arousal and the intention to drink and/or use the drug. It might include permission-giving beliefs that patients hold to justify their drug use. I'm just going to do it one more time. I just need to do it until I get my stress under control. It might include adverse psychological reactions to a lapse or a relapse, both of which are incredibly common, but they might lead to a vicious cycle of feeling more and more hopeless and using the drug as a way to cope. And remember to always look for underlying or concurrent factors. With addiction, there is nearly always stress, depression, anxiety, and a profound lack of connection. Hopelessness is common. Fortunately, CBT tools can address all of these. If we go back to our foundational skills, we want to look at self-awareness and self-monitoring, identifying triggers, supports, and obstacles. We want to look at cognitions about coping, substance use, and pain, and we want to assess and track mood. Our behavioral skills will bring out our activity scheduling. Again, we want to address that anhedonia, and we will expect this to be quite difficult. We want to use some somatic quieting to lower the level of arousal and to help him cope better with stress. We want to teach him those interpersonal skills, those communication skills of how to refuse drugs when they are offered, and social activities that might help him to build a new network. We're going to want to use stimulus control, so limiting access to opioids, limiting triggers and cues that might make him want to use opioids or to trigger cravings. If he does have a craving, he needs some skills in place that will help him deal with that craving. They might include things such as attentional deployment or distraction. It might be reframing those sensations, addressing misperceptions about craving and how bad it might get, or misperceptions about the course of substance use disorders. Remember, most folks who have had an opioid use disorder do get better. We might include things such as physical exercise. Craving can serve as a trigger to engage in physical exercise. Or he might try substitution. So instead of using an opioid, he might try a different strategy to help him manage the pain. His cognitive skills might include looking at his primary and secondary appraisals to help him to manage stress. It might include thought records, cognitive restructuring, looking at his beliefs about self, others, and the world, including beliefs about his family, or maybe even beliefs that he has about his medical team. So fortunately, there are lots of tools that could help. The challenge then is coming up with a coherent plan, a plan that will be driven by goals set by the patient. Now, some patients want total abstinence. Some want to continue pain medications. Some want to continue recreational use but reduce harm. What are the elements of a good plan? Well, it matches the patient's level of readiness to change. It enhances motivation by keeping the issue alive in the patient's mind, and it reduces harm and/or provides an important learning experience. It's concrete, specific, realistic, the patient agrees to it, and is able to repeat it back. So here are some plan examples, and consider the micro skills that you might need to employ for each of these. So he might want to learn more about opioid use disorders or about pain management. So here we're talking about simply an educational intervention. We might get him to monitor use. So he's not changing anything, but is at least gathering some data about his use. He might set the goal of reducing use or maybe reducing harm. He might explore different treatment options, not enrolling, not starting, but again, sort of gathering information about what's out there. He might decide that he wants to abstain from opioids entirely, and then of course we'll want to think about other pain management interventions. Or he might decide that he wants to enroll in a treatment program that can help him get off opioids entirely, or maybe transition to a drug like buprenorphine. What makes opioid use disorder so incredibly difficult is the strong biological need that develops, a need that if not answered can be excruciating. Fortunately, there are medications that can greatly help and are an essential adjunct to CBT. Let's watch this next clip.
So I know you're on opioids now. The goal is to taper you down, to add in some medications for neuropathic pain. Gabapentin is probably the most likely choice. I'm wondering if you've heard of medications specifically designed to treat opioid use disorder while still giving you some pain relief.
I have not.
Okay, so there are actually 3 that are out there, and we really talk more about sort of 2 of them. One is an opioid blocker, and most folks don't like it because it doesn't help you with pain at all. In fact, it might amplify pain a little bit. If you take it, then you take an opioid, the opioid does nothing, but that also means you're sort of left with your pain. There are 2 others that are in the opioid family. Methadone is an older drug. It does help with preventing withdrawals from happening. It can help with pain management.
That's for heroin addicts, right?
Well, you know, people that do have a heroin addiction, heroin is an opioid too, and it's a way to keep them from using heroin. So it occupies the same receptors, gives them some potential pain relief if that's an issue, but mostly used to prevent withdrawal. We know it's especially important these days now that a lot of heroin is contaminated with fentanyl. That's why a lot of folks are having these overdoses. They don't realize what they're getting. So methadone is a good option for them. You do have to go to a special clinic to get it. A lot of times you have to go there every single day, so it can be pretty inconvenient. There is a newer drug, it's called Suboxone is the trade name, but it's buprenorphine is the generic name, and it is a partial agonist, which means it occupies the same receptors. It doesn't give people a high, doesn't give people the same kinds of side effects that you might get from, say, morphine, but it does prevent withdrawals. You take it either once or twice a day, depending on the size of the dose, and you actually dissolve it under your tongue. So it's a little bit different. Prevents withdrawals, gives you some pain relief, but again, you know, we can't just rely on one thing, on one medication. It'll need to be part of an entire package. So has your pain management doctor talked about any of those yet?
No, he really hasn't. I mean,
okay.
It's good to know about options. I kind of thought, you know, we're kind of running in place just doing the same thing, so.
Okay.
That's not going to make any kind of change.
Okay. So what we do is I'll give you some handouts on, I'll just give you both, so methadone and buprenorphine. And I would encourage you to talk with him about a cross taper. So as they're tapering you down on things like morphine or OxyContin, they can be tapering you up on buprenorphine. We'll want to be measuring your pain as well, getting you started in those other interventions like physical therapy and cognitive therapy. The other medication is naloxone. That is the drug that's given to people if an overdose has happened. So it comes in several different preparations, but the nasal spray is most common. And I think it's important that you have a prescription for that. You can get it at just about any drugstore that's out there, and it's good just to keep it at home. Make sure your wife knows where it is, you know where it is. So if something happens you do take too much, or there's a contaminant in some opioids that you've taken, then that's the way to save your life, really.
A federally funded report recently released came to a striking conclusion. More than 80% of the roughly 2 million people struggling with opioid addiction in the U.S. are not being treated with the medications they need to prevent withdrawals or to prevent overdose. Methadone was approved to treat opioid addiction in 1972, and buprenorphine in 2002. Some countries have shown that increasing access to these drugs can significantly drive down the rate of overdose deaths. In France, for example, policies that enabled more doctors to prescribe buprenorphine helped lead to a tenfold increase in the number of people whose opioid use disorder was being treated, and to a nearly 80% decline in overdose deaths in just 4 years. In many states, would-be buprenorphine prescribers must wrestle with insurance companies for reimbursements, restrictions that are not justified by scientific evidence. These restrictions also don't exist in other countries, and they aren't applied to other diseases. Less than 7% of medical providers have gone through all the hurdles needed to prescribe these life-saving treatments. As a result, more than half of all counties have no licensed buprenorphine prescriber at all. This affects adults, adolescents, children, pregnant women, all populations that might need this medication. Public health forecasts indicate that opioid overdoses might claim another 500,000 lives in the next decade. Many of those deaths could be avoided if existing medications like naloxone, which reverses overdoses, or buprenorphine, which treats opioid use disorder, would just be put to use. I'd like to share one last bit of late-breaking and encouraging news. Researchers at the University of Utah are busy at work testing a hybrid therapy that combines CBT and mindfulness. They call it MORE, M-O-R-E, or Mindfulness-Oriented Recovery Enhancement, developed by Garland around 2016. It includes mindfulness, plus savoring, a tool that you already have in your toolkit, plus cognitive reappraisals, again a tool you already have in your toolkit. It helps patients shift from affective to sensory processing by having them actually fill out what they're feeling in their bodies using what's called a somatosensory mannequin. Just a picture of a person, what hurts and what feels good, then using mindfulness. What they've shown thus far includes decreased attentional bias and craving, and less arousal around triggers. Importantly, they're also showing increased functionality. So let me give you an example of some of their savoring exercises. Now, we've all probably done the mindfulness exercise with the raisin before, but they also take a flower and they describe what it is that they're seeing. They listen to music and they describe what it is that they're hearing, but also what the music evokes within them. What's happening here? Well, remember that process of hedonic dysregulation. We're pushing back against that, trying to bring in enjoyment, but maybe it's also a little bit of attentional deployment or distraction. Now, if you or someone you know might have a problem with opioids, I would encourage you to reach out for help. Consider these resources: the SAMHSA Treatment Locator, which helps you find a treatment facility, the Patient Resources page of the American Society of Addiction Medicine, or the recently founded National Helpline at 1-800-662-HELP. That's 1-800-662-HELP. Please join us for our next lecture, where we leave clinical disorders and talk about an all too common problem, perfectionism. I hope you'll join us. Thank you.